this in person. This is the first time we're doing this in person since the start of the pandemic. I'm Bon Ku. I'm on faculty here at Jefferson, and I run a group called the Health Design Lab. I want to welcome students, faculty, outside guests, and folks joining in online in the virtual audience, and friends and family of Dr. Spivak. There's a lot of people working behind the scenes to make this happen. I want to acknowledge Morgan Hutchinson, Rob Puglisi, Mary Ellen Daly from the Health Design Lab and Innovation, the Provost Office, Charlie Pohl and Richard Crespo, Lauren Carney in the Office of Institutional Advancement. This is my favorite event of the year, and this year's speaker is a colleague and friend of mine, Dr. Neel Shah. He has a long CV. I've abbreviated it, but I'm going to give you some highlights. Neel Shah is the Chief Medical Officer at Maven Clinic. He's the visiting scientist at Harvard Medical School in Boston. He's also in his spare time, he's an OBGYN at BI, Deaconess Medical Center in Boston. And he's globally recognized as an expert in designing solutions that improve healthcare. Becker's Hospital Review named him one of the 40th smartest people in healthcare. I think it's one of the top 10, but we'll give them that. Neel works to build equitable, trustworthy systems of care, and he's been profiled by the New York Times, CNN, and is featured in the documentary Color of Care that's produced by Oprah Winfrey and Yance Ford. It's a great documentary. You should check it out. Neel founded Cost of Care. That's an NGO that curates insights from clinicians and patients to help delivery systems provide better care. I'm almost done here. In 2017, Neel founded the March for Moms Association. It's a coalition of more than 20 leading organizations. And what it does is it increases public and private investment in the well-being of mothers. In his spare time, Neel serves on the National Advisory Board of the Office of Women's Health Research at the NIH, and as the founding director and senior advisor to the Delivery Decisions Initiative at Ariandi Labs. Today, Neel is going to speak about his work and his creative journey in medicine. And afterwards, he'll be joined by President Dr. Mark Tykocinski for a fireside chat. And if there's time, we'll have some few questions from the audience. And now it's my honor to introduce President Tykocinski. He's one of the most creative leaders both in academia and healthcare. He's really personally catalyzed my path to combining the fields of medicine and design. His vision for redesigning the future of health celebrates the skill set of creativity. Join me in welcoming President Tykocinski.
So, Bon, I noticed you said you called him one of the top 10 smartest people. I only got a creative out of it. So I'm really intimidated for my time on stage with him, but I'm sure I'll come up with a good question or two. Bon Ku is a prime example of when you take somebody who's a firebrand with tons of energy and unbelievable smarts and just unleash them. And Bon, what you've done here for Jeff Solves, the Health Design Lab and everything is truly remarkable. And one of these days, we're going to have to really celebrate you personally and what you've accomplished here. Let me just say that what we've tried to instill here through the work of Bon and all his colleagues here is this notion of human design thinking. And human design thinking can take you in a lot of different directions. And what I love in particular is some of the best solutions don't require fancy engineering and programming, but just sort of simple low-tech solutions. And one of the things that I've loved about what our students have done, often medical college students in conjunction with design students, textile students, architecture students, is identify a problem that everybody didn't even realize and hadn't recognized, and then in a couple of months come up with these unbelievably creative solutions. But the solutions also can be in process. And I think what we're about to hear from Neel Shah is when you apply those kind of design thinking principles in terms of human behaviors and systems and how you can make things happen, that becomes particularly powerful. I understand that this is being live streamed, and Al Spivak's daughter, Laura Garfinkel, will be listening. And so to Laura and the rest of the Spivak family, I can't tell you how unbelievably humbled and honored I was when Al, endowed this professorship in my name. I'm just used to everybody else getting named and honored, and then all of a sudden, and I tried to talk my way out of it. I truly did, but this was him. He really embodied that multidimensional physician. He had this unbelievable love of creativity. He was a ceramicist. I actually have, two of his pieces, and just an absolutely remarkable human being and an alumnus of our artist that I'm extremely proud of. So I actually have to introduce our Spivak scholars. So we have just unbelievably creative medical students at this institution. A lot of them, a bunch of them get involved in the Jeff Solves program and the design lab. And each year, with the support of Al Spivak's generosity, we name 4 students who get scholarships towards their tuition that year. And this year's Spivak scholars are Lauren Schlegel, Zane Gouda, Maya Reed, and Bo Yun. So congratulations to you, and we're really honored. You're gonna get a picture. Without further ado, if our Neel, if you could join us.
It's interesting to be on a stage, like a real live stage. Congratulations to all of you on the scholarship. Thank you for having me here. Been a long time admirer of Bon Ku, and so it's really special to get to visit and be part of this community for an evening. I think what I'm going to do is I put together some notes on my phone, and then I've got a mixtape of slides that maybe we'll step through, and maybe just in level setting. What I want to do is tell you a little bit about who I am, what I do, why, and then hopefully there's something useful to walk away with from that. Maybe I'll start with what I'm not. I'm not a mother. I don't have a uterus. You're like, really? I've never been pregnant. But for the last 15 years, I've dedicated all of my professional energy to caring for people who are. I am from Boston. Actually, I always clarify, I live most of my life in Boston, but I'm from New Jersey. The first time that I did CPR on a pregnant person, I was a newly minted doctor just a month into my intern year. One moment she was speaking to her husband, and the next she turned blue. I started chest compressions while my senior resident did an exam to check how close her baby was to delivery. And from my memory, honestly, most of it was a blur. What I know is that we rushed to the operating room, we restarted her heart, and her baby survived. We later learned that the cause of her heart stopping was something called an amniotic fluid embolism. It's a catastrophic but extremely rare event that almost always requires a heroic rescue to be effective. And so my initial understanding of maternal mortality was exactly that. Catastrophic but rare event that required heroic rescues. But the more experience I gained practicing medicine, the more that I observed that most catastrophic events are actually preventable. that short of these catastrophic events, were many near misses, and beyond my immediate field of view, some people are at far greater risk than others. In many cases, it was not at all because of their biology, as I had learned in medical school, but because of the ways in which our society had made them vulnerable. By the way, COVID-19 took every inequity in our society and just threw it into a pressure cooker. And I'm sure, everybody in Philadelphia saw a version of that. I certainly saw a version of that in Boston. There was a version of that in New York. In fact, a lot of my family is from Jackson Heights, Queens. And for a while, the Elmhurst Hospital there was really the epicenter of the whole global pandemic. And so, my instinct through the course of training in a tertiary medical center as an OBGYN was to widen the aperture a little bit on maternal mortality, which led me to first become a researcher, and then a public advocate, and then of all things, a technology executive. So I want to explain that a little bit. Actually, ignore that for a second, because I want everybody to just absorb a couple of statistics. As a professor, I did what professors do. I analyzed reams of data. And by the way, there was very little data to analyze on maternal health a decade ago, not that long ago. There was things that people knew and saw, but in health services research, you usually go to insurance claims and typically to Medicare claims. But there aren't a lot of people over 65 having babies. It's probably for the best. And so, the alternative is 50 different Medicaid systems, which are really hard to access. It's a little bit of a wonky, tangent here, but just to, is there any health services researchers here that are feeling this with me? No? Okay. One, it's just really, really hard. And in absent claims, you had birth certificates, and people like me fill them out. So they were terribly inaccurate. But anyway, I analyzed the data that I could find. And I learned that a person in the United States today is 50% more likely to die in childbirth than her mother. I'll say it again. A person in the United States today is 50% more likely to die in childbirth than her own mother. 3 to 4 times more likely to die if she's Black or Native. And, that's just the tip of a really deep and wide iceberg, because for every death, death is the lagging indicator. For every death, there are, tens of thousands of people who experience major injury or morbidity. And for each person who experiences a major injury, there are tens of thousands more who suffer from undertreated illness, economic disempowerment, social isolation, all the things that are part and parcel of being a mother in the United States today. So that's pretty stunning. And, part of it was really hard is I was a forward deployed, seemingly well-trained and compassionate obstetrician. And I thought I was doing a pretty good job at taking care of people, but it was really hard to reconcile those statistics against the good care that I was giving. So for example, maternal mortality has gone up by 50%. At the same time, mortality for term infants has held steady at 0%. But our C-section rate has gone up by 500% in that same time period. So we've intervened with heroic rescues, 500% more, major surgery. And for that, we've gotten 0% gain for term infants and a 50% increase in maternal mortality. And whenever I do a C-section, by the way, I'm always right. Because if you do a C-section and the baby comes out looking blue and has low APGAR scores and is kind of lackluster, you're like, well, it's a good thing I did a C-section. I was a sick baby. And then if the baby comes out looking pink and has really good APGAR scores, you're like, it's a really good thing I did a C-section. See? So it's pretty good to be me. The thing is, we can't all be right. It's not just that C-section rates have gone up by that much. It's that, all of the conventional wisdom to explain why doesn't bear out. So people are like, oh, moms today compared to moms a generation ago, they're older, there's more chronic conditions and obesity and hypertension, diabetes and IVF, since there's more multiples, and moms are different somehow. But a healthy 18-year-old today is twice as likely to get a C-section as when she was born. So it can't be that. And if you look out across the country or even within like the greater Philadelphia area, there's incredible variation in C-section rates by hospital. So from one hospital to the next, sometimes within the same zip code, the hospital C-section rate can go from 7% to 70%. There's nothing in healthcare that varies 10x from hospital to hospital. And you're like, okay, well, you know, the patients at Jefferson are sicker than somewhere else. But if you only look at the lowest risk women, you would expect to see less variation, right? You see more variation. Instead of 10x variation, you see 15x variation. So, and it was really hard to explain. Like risk adjustment didn't explain it. And again, there was no data. So again, a little bit of a tangent, but it's kind of interesting. It's part of what connected me to Bond. In the absence of data, my mentor, who was a journalist, told me to just go visit a bunch of hospitals. Actually, it's one of the greatest gifts he ever gave me. Or really anybody's ever given me in my career. I started my faculty job with like 100 ideas of things that we were going to study. And he said, take your first year, drop into as many rabbit holes as you want to, but come back to me with the one idea that's going to make the biggest difference. And so, you know, the first year of my career was kind of going on an Americana tour and seeing what it was like to give birth outside of Boston. And it's different, turns out. Giving birth in a birthing center outside of Albuquerque versus a critical access hospital in Wyoming or New Hampshire versus a tertiary center in California, really, really different. And one of the things that we found is that if you peel the roof off of the hospital and look down, you can totally explain the variation in what's happening. And that the sources of truth, the data, are not what people would expect. So now you can look at the slide. We came back with a cartoon. After a year, we came back, this idea of a pressure tank. And by the way, there's a version of this in the emergency room too. But in life and in healthcare, you're often facing a dichotomous choice between doing the right thing and doing the easy thing. And they don't line up, right? You're in the emergency room and you can either figure out how to coordinate somebody's care, or you can just call the hospitalist and admit them. If you're me and someone's on the labor floor and they have, you know, an ambiguous fetal heart tracing and their labor is taking a little bit longer than you think it should, you can either persist or you can do a C-section. And then it turns out there's different things in that pressure tank that influence how likely it is you are to move in one direction or the other. So one of the interesting things that came up along the way is there are no rules for how many labor and delivery rooms you need based on the volume of people you take care of. There's like vague rules of thumb. There's no like actual rules. So we figured out there were two hospitals on the West Coast that both did the same amount of deliveries. Oh, excuse me, no. Two hospitals on the West Coast, they both had the same number of labor and delivery rooms, but one hospital did twice as many deliveries as the other. And they both thought they were at their capacity limit. But the only way that's possible, according to Isaac Newton, is if one hospital is moving people through a lot faster. So then we realized that every public use facility has a fire escape map somewhere in a visible location, and that was data. It wasn't HIPAA protected. People could just take pictures of it and send it to us. And we could use that to know how many rooms they had. And if we knew their delivery volume, we could directionally predict their C-section rate. If it was above or below the recommended threshold. So, I mean, we did a lot of cool things. I was really proud of the ways that we unmasked a lot of the data and were able to explain it and drive a public discourse around it. As a scientist, I firmly believe that you can't fix what you don't see and you can't see what you're not measuring. We didn't even know that maternal mortality was going up until about 2017, 2018. And it wasn't because the CDC was ringing alarm bells, it was because of gumshoe journalism. A reporter at ProPublica and NPR got together and started to go to local newspaper obituaries and Facebook to do a manual count and tell stories. In 2018, a coalition of stakeholders helped pass a federal bill called Preventing Maternal Deaths Act. In fact, the longest furlough in government history when we couldn't pass a budget was in 2018. And right before the government shut down, this was the last bill to sneak through. And All that law did was make it so that we're systematically collecting maternal mortality information. There's a wonky reason why we weren't doing it before. It turns out federalism sometimes works against us and maybe sometimes for us. But in this case, every state was collecting information differently. And you can imagine that attributing a death to a maternal mortality event is subject to some interpretation. So it was different. We didn't have a systematic way of doing it. Now we do. And now that we have a definition of what a maternal mortality event is, that allowed us to, understand how many of them were preventable. So in 2018, the CDC believed that 3 out of 5 of these deaths were preventable. Here's the thing, like what science gets you is confidence that what you think you're observing is true. That's really important, especially in 2023, because like, who knows? Spend enough time scrolling through Twitter like I do. I wouldn't recommend it. Like seriously, like who knows? Science is very important, but it doesn't lead to change without advocacy alongside it. And, I don't know how you were all trained, but at least in my training environment, scientific equipoise requires not taking a position. You're supposed to drop a rock and drop a feather and like be agnostic to what hits the ground first, But in the real world, there's always someone blowing on the feather. Anyway, so in 2018, 3 out of 5 deaths are preventable. But in 2022, just this last summer, the CDC changed their definition of preventability. And because of powerful advocacy, we now believe that 4 out of 5 deaths are preventable. And we no longer think of prevention in terms of what's on the death certificate. People are not dying of hemorrhage. The number 1 cause of maternal mortality is cardiovascular disease. But everyone who dies, their heart stops. People survive massive hemorrhage and they don't survive more moderate ones. The difference is always systems. The plurality, if not the majority, of maternal mortality can be addressed much more upstream. We now realize that not only does racism impact maternal health, but maternal health is one of the leading indicators that racism is a clear and present danger in the United States. We realize that at least 10% of maternal mortality is due to personal safety and mental health issues. Going back to COVID for a second, it really placed the degree to which maternal health is a bellwether for the well-being of society as a whole into stark relief. So now understanding of preventability and maternal mortality really comes from the understanding that, every form of injustice shows up in the well-being of moms, whether it's racism or gender inequity or geographic inequity. Or generational inequity. Whether you're sort of like in the Make America Great Again camp or the Build Back Better camp, there's actually a very similar sentiment in both, believe it or not, which is that hope and opportunity in our country are eroding. That's the sentiment. And there's objective data behind it. Generationally, like mom is more likely to die. In my career, I've been privileged to work alongside people who know this in their bones. People like Wanda Irving, Charles Johnson, Bruce McIntyre, Shawnee Gibson, who in the memory of their lost loved ones, Shalon Irving, Kira Johnson, Amber Isaac, Shamani Gibson, persisted in holding power to account and launched a movement to correct these injustices. This is Bruce McIntyre. And his partner, Amber Rose Isaac, lost her life at the height of the pandemic in New York City in April of 2020. And it was like, not the kind of racism that you are taught is evil growing up, right? And that's like the challenge with racism. It's like people like bristle, and it's really hard for them to hear that that's a root cause because you're taught that it's evil and you don't think of yourself that way. But what happened was, during the pandemic, people who were pregnant were like the last ones that you wanted coming into the hospital. And when you're counseling people about pregnancy, you're often just reassuring them that everything is okay. It's like what a good provider does. But our thresholds for deciding people are okay differ based on biases that we hold or whatever the case might be. And in her case, Amber called with concern about symptoms over and over and over again. And a really overcapacity health system wasn't able to get her to in-person care in time. What I learned from getting to know Bruce and some of these other advocates is that, you know, I really learned this. This was actually a Deming quote, but I really learned this. Every system is perfectly designed to get the results that it gets. So if the system is unjust, it was designed that way and it has to be redesigned. I also learned, and this is very important, a bad system will beat a good person every time. I actually think that almost all maternal deaths are preventable if you just open the aperture enough and you go beyond the death certificate. You know, health isn't produced within the four walls of our clinics. It's produced in people's homes, in their communities, in their workplaces. We have a rescue system. We don't have a prevention system. And if we adopted that frame, I think this graph, hopefully in 5 years, will look really different. By the way, preventability is the leading indicator. Mortality is the lagging indicator. So if we see that more deaths are preventable, that's a good thing. That means we're identifying the right people. And just to give you a sense here, you know, part of what challenged Bruce is that he was from the Bronx. So even within New York, there's a big difference between living on the Upper East Side and living in Jackson Heights, where my family is from. But you look out across the country and 90% of our land mass is rural. 1 in 5 families lives in one of those places. And only 50% of US counties have a qualified childbirth provider in 2023. In 2023, the farthest you have to drive in Kenya to get to a qualified facility to deliver your baby is 3 hours. There are parts of our own country in the heartland where you have to drive farther than that. So that's tough. Mothers are unwell, society is unwell, and vice versa. So 18 months ago, I gave away all my grants, took a leave from the university, and decided to do something different. Spent a lot of time peeling the roof off of hospitals, trying to understand what was happening inside, how the architecture and how the systems and all the different processes can be optimized to take better care of people who are giving birth. But, you know, and by the way, like that brick and mortar physical system is irreplaceable, okay? Like an app isn't gonna fix healthcare. You cannot deliver a baby through a screen. You just like level set and agree to that. Also, boy, is that brick and mortar system sclerotic when it comes to change. I mean, even prenatal care, we had a century-old model of prenatal care that hadn't changed at all. It's like fixed. And then the pandemic all of a sudden created 1,000 natural experiments for how to do prenatal care because we're like, maybe pregnant people don't have to come in 14 times and it's okay. So what did I do? I joined Maven Clinic. So Maven Clinic is a digital health company that enables people to use their phones to access care and support, no matter what time of day it is, no matter where they are. The purpose of a startup should be to meet an unmet need sustainably and at scale. One of my challenges in academia is that nobody wanted to buy what I was selling. So, you know, like we helped shape a discourse and we put ideas out there and we demonstrated that they worked. I was like, that should be enough. But we didn't have product market fit. Didn't have the language for it then, but we just didn't. And Maven Clinic seemed to. In a short period of time at Maven, we've reached a point where we're, you know, operating in all 50 states, serving people in 170 plus countries, serving millions of people who are commercially insured, people who are publicly insured, people who work in retail, manufacturing, education, every industry and sector. And, you know, my actual, like, I feel like I'm sitting in the panopticon right now. And my like view of the American healthcare system has really changed from being a health services researcher, because as a health services researcher, people were publicly insured or privately insured. And that's just how I saw the world. But it turns out you can work for the world's largest technology company and still, you know, day to day be in a fulfillment center and be as vulnerable as someone who's publicly insured. You could work for a big bank and, you know, be a teller. And from that vantage of sitting in the panopticon, the opportunities for the American healthcare system are pretty clear. Just to give you a sense, I mean, one of the biggest challenges, I think, right now when we try to get a prevention system up and running is that right now, where you are physically determines what you have access to. But that need not be the case in 2023. You can create economies of scale with digital health. Like Zooming for a clinical visit is not digital health. Like there's some things that always have to happen in person. There's some things that could happen in person or could happen digitally. But what's most exciting to me are the things that can only happen in a digital environment. Like I still have a brick and mortar clinic, and I think all the time about like, what can you get done for someone in a punctuated 15-minute visit? And what could you do if you could actually meet them in their homes, in their communities, in their workplaces 24/7? So let me give you some examples. Somebody is struggling to breastfeed at 3 a.m. Maybe in some parts of the country, they can meet with a midwife or a lactation consultant or someone who has expertise in breastfeeding. Usually it's their pediatrician who's on the hook for helping them while they're also trying to attend to a vaccine schedule and other things. And usually it's booked a couple days out. But if you can connect with someone within 30 minutes while they're actually struggling to get a latch and look through their phone at what they're doing, it can be the difference between them like giving up or persisting. And that can make a big difference for someone. If someone has gestational diabetes, they don't need an obstetrician primarily. They need a nutritionist. Changing your diet is very, very hard. And easier if you can talk to someone within 30 minutes who can look through your phone at your refrigerator and help you plan a meal in real time. It's like a game changer. It's the difference between a 34-week delivery for glycemic control by the guidelines or a full-term delivery. So anyway, I think I'm going a little bit long here. So I'm going to wrap up by saying it's not the job of people the health system serve to be more trusting of us. It's our job to be more trustworthy. And to me, trustworthiness is more than a virtue. It's an output system that's actually working for people. And I think the biggest challenge that we have in our delivery system is reliability. We're not showing up for people when they need us to. If I were to tell the clinicians in my health system right now that they had to text the patients back, they'd probably like break because they have no way of doing that. They're not set up to do that. But as soon as you enable that capability, like people engage with you. And I think all the time about how in digital health, there's nobody in the waiting room, right? There's no captive audience. People can put their phone away. So you have to be really, really sharp about engaging people in the right ways so you earn the opportunity to try and make them healthier and support them. So we've got to invest in digital technology that can bypass clunky systems and provide modern means of accessing care and support. That won't be enough. We also have to platform and amplify community-based organizations who are best positioned to surface solutions. By the way, I think the birth equity movement in 2023 is roughly where the HIV/AIDS movement was in 1987. There's a great book on the organization ACT UP called Let the Record Show. It's like 800 pages, pretty thick, but it's like a tactician's like playbook for how to create a successful social movement. ACT UP, very similar. There was a group of people who were disproportionately affected by an epidemic. They were disenfranchised. The Reagan administration was not attending to their needs. Pharmaceutical companies weren't. ACT UP organized. They got AZT passed. They dropped mortality from HIV by 70%. And they made it so that in 2023, you cannot do HIV/AIDS research without a community advisory board. Like literally the playbook for holding power to account. And I think the birth equity movement is in the same place. Interestingly, one of the lessons was not everybody in that movement got along. It was often represented by, like Yale-educated white men. But within the movement, there were people of color, there were lesbians, there were people who just had different interests and points of view. And one of the biggest insights from the book, especially in these times that we live in right now where nobody can seem to get along, is that you don't need consensus for progress. You need what the author Sarah Schulman calls simultaneity of response. You need everybody acting at the same time and playing their part. So I think about that a lot, as CMO of Maven Clinic. I can't be the tip of the spear on, reproductive justice issues all the time. there are community-based organizations that absolutely can and need to, and then they give us cover, right, to like work within the channels that we have. Final thought here. A couple of months ago, I was talking to Loretta Ross, who is the person who created the reproductive justice movement. And that was 50 years ago. Interestingly, 50 years roughly bookends Roe v. Wade and the Dobbs decision. And I asked her how she maintains a sense of optimism, given that seemed like a massive regression from where she started. And she said that you should never, and by the way, everything that she says is like this. It's like off the cuff. It's like being taken to church every time. She literally said this. She said, you should not imagine yourself as the entire chain of freedom. You're not responsible for what your ancestors did, and you're not responsible for what the people come after you do. She said, your job is to make sure that the chain does not break at your link. And so when the world's a mess, you should grab a broom, clean where you are. So that's what I have to say.
Thanks a lot, Neel. So, let me start with maybe a more provocative question. And I'm really taken by your comment about just one little piece of what you were talking about is the issue of false reassurance. And I think part of the problem in our system is decisions in the pressure cooker, the triage decisions that are made. And I think that's what you're alluding to in part, where bias, racism, those things sort of can factor into that. So in a sense, we need objectivity in that at those decision points. And since the conversation of the moment is around ChatGPT, and I'm all knowing nothing about AI myself, but enamored by the power that I'm told suddenly AI has leashed, I think we're probably only a few years, or maybe who knows, a few weeks away from physician ChatGPT that takes that woman at home at 3 a.m. and trying to decide whether they need such and such care, or you connect through Maven Clinic to that specialist, but who says the specialist isn't going to sort of draw on a personalized approach as opposed to a data-driven approach. So in a very sort of open way, where do you see sort of these new AI tools to sort of democratize data interpretation?
That's a great question. I was wondering where it was going to land. I will say
I was trying to decide myself.
Yeah, no, I mean, like
as I was navigating all these
totally have a take there, though. So this is something that I've learned in working really closely with the technology side of my own company. First of all, a good product developer has a different source of truth than a clinician. It's interesting. A good product developer, their source of truth is always the end user. And like, if healthcare had more of that, it would be a lot better. Also, the source of truth for the clinician is an evidence base. And they're like, what is that? And an evidence base is usually some kind of epidemiological study that is primarily concerned with central tendency. It's a little bit wonky, but what happens on average is useful, but doesn't tell you how to take care of the person directly in front of you, because what epidemiology doesn't do is tell you about the variation around the mean. And that is where I think, machine learning and AI can be very helpful. ChatGPT is a very specific use case, and we've got to be very careful with this technology because all it does is predict the next letter. Like ChatGPT has no idea like what's happening logically. And so, there are great use cases for it. For example, it's already being used to expedite prior auth. Doximity integrated ChatGPT. You can use it right now to expedite prior auth, and probably a great use case. And also, it is wrong a lot. But to your point, I think more on the philosophical level, I think it's awesome that ChatGPT can pass the USMLE. And I think it can. There's a paper on it already published. And, we shouldn't be intimidated by that. We should embrace that, right? I mean, we're already at a point where Remember when I was starting that nonprofit Costs of Care, part of the whole thing was like clinicians have no idea how our decisions impact what people pay. And, educators would come up to me. I remember actually being at the AAMC meeting. And, they'd come up to me and they'd be like, how can clinicians possibly keep track of this information? They've got so much they need to know. And I was like, also true about genomics and so many other things. So if we can get better at knowing how to apply evidence, make that the thing, as opposed to knowing the 5 causes of chest pain, I think that would be a good thing.
Well, I think part of the challenge will be using these kind of data gathering and technologies to make sure we haven't overlooked things, but ultimately we're going to have to use the human mind to parse that information and test it.
Always.
Yeah.
Yeah.
And I happened to be talking to my son yesterday because he does investment work in these kind of spaces. And I mentioned ChatGPT. So he looked up my name and it got a lot right, except it had me going to the University of Michigan. I think that sort of highlighted what the challenge is. But I think it also sort of begs the question, all of this of what should we be doing about physician education, right? Right now we have, we're about to go through our LCME reaccreditation for the medical college. We're locked into a system that is really archaic, notwithstanding all the changing of our curriculum in the last couple of years, making it more Socratic with more small groups, all of that. But in the end, we're still structured in the same way. What are your thoughts about, where the future of medical education? Where do you think we need to take it? What in a digitally powered medical world, what is the physician going to be doing in 10 or 20 years?
That's a really great question as well. And I promise I'm not pandering with this, but I think part of it, the answer is to come to Jefferson Medical College, because my favorite definition of a designer is Henry Simon, who said that a designer is anyone who changes existing situations into preferred ones. Kind of like that. I think what was missing in my own medical education was being able to do systems thinking. I think that my mentor Atul Gawande put this best. He said the last century was the century of the cell, where we spent all of our innovation energy in subdividing the human body into smaller and smaller parts in order to understand what every cell does. And now the big challenge is putting it all back together again. The dominant cause of human suffering in 2023, it's not actually lack of knowledge, it's lack of execution on the knowledge that we have. Because we don't have enough forward deployed people that can understand how they're positioned or situated within the larger system and what they can do about it, which is also why I think we have so much burnout.
Yeah, and I'm always struck by how the more you start to appreciate complex systems, it doesn't necessarily mean that the solutions have to be complex, right?
I loved that you said that, by the way. I think that the best solutions are the ones that don't have a black box, right? Like, I think good designers are really good at finding the distillant. Like, what is like the thing? And even at Maven Clinic, we're a technology company, but we're not splitting the atom, which I'm comfortable saying publicly. We're not. Like, our whole care model is that we're just finding people who need more care and support and giving it to them, right? And I'm enormously skeptical of black boxes and AI for its own sake.
Yeah, and I think it's also an issue of solutions that are tailored, that are practical and tailored to the population. So we have at Jefferson, we have a global center model. We have a handful of countries where we develop relationships, and there's a logic to each one. So we're deep in India. We have a Jefferson India Center through the work of Richard Derman, focused on maternal and women health. I think it's probably one of the top 3 or 4, frankly, in the country. And what I love about the work that Richard and his colleagues in India are doing is it's simple, tailored solutions. So they just, are completing a study where a single shot of azithromycin before delivery creates a massive benefit of maternal sepsis. So you don't need some fancy new drug out there to do it. It's just a shot of azithromycin. Similarly, for anemia of pregnancy, which in a lot of the world is a major source of morbidity and mortality, a single shot of iron, right? So there are these low-cost interventions, and it simply requires looking at a problem through a clear lens and then trying to, come up with that, with a solution around it.
Just to riff on that idea, there's so many examples exactly like that. I mean, like oral rehydration therapy for cholera was like water, salt, sugar, boom, like so many lives saved. Surgical safety checklist. And then it's also a great example of like, there's a time when people are like, oh, the checklist drops mortality in half for every surgery on every continent, has as much impact as like the smallpox vaccine. And so there was an era not too long ago where we're like checklisting everything. And there were terrible checklists because they weren't simple. They thought checklists were writing down every single thing that you could possibly do. But the best checklists distilled down of the many things that you could do, the things that you should do consistently every single time, towards that principle of simplicity.
Yeah. I love that. So you touched towards the end about Maven Clinic, but I'd like to hear a little bit more about that. So
yeah,
what is sort of the core concept there? I know you're making connections and bringing access.
Yeah.
But exactly sort of what's the magic sauce?
Well, the magic sauce really is using like telecommunication technology for what it's for. So when I joined the company, Maven Clinic is about 8 years old. I joined a year and a half ago. And the chassis of the product already had the capability of using the economies of scale that you get from not being geographically tethered to connect you to a lactation consultant at 3 a.m. or to make sure that if you live in the Mississippi Delta, you can connect to not only a nutritionist, but one that looks like you, when most of the providers don't. And my job was literally, how do you deploy that capability to demonstrably make people better? Because, innovation in healthcare is hard. Changing systems is really hard. But what Maven did, and we actually just taught the Harvard Business School case study on Maven a couple of weeks ago, where the purpose of the case study is to illustrate how you convert from a direct-to-consumer business to what's called a business to B2B business. And so the direct-to-consumer was, in the first couple of years of Maven, it was like, do people want this? That's it. Let's just go right to the people. You want to be able to act? Do you think you have a UTI? Have you had UTIs before? You want to just talk to somebody about it? You just need your birth control renewed? Like that, and people wanted it. They wanted it. And so then what happened is we became an employer benefit, which allowed us to reach more people, to work with retail, to work with the financial sector, to work with, and then when I was about to join, the opportunity was to reach the largest addressable population, to go into Medicaid. And in Medicaid, the care model is not rocket science. It's like, find the people who need more care and support and give it to them. What's hard is the unit economics, because the willingness to pay in Medicaid is lower, as we all know, in working in healthcare. And so the only way to make it work is to put your fees at risk. And the only way to put your fees at risk is to have reproducible outcomes. And the purpose of science is reproducibility, which is why they hired a scientist. Even though I didn't have experience as a business operator, that's worked out okay.
Yeah, well, I think you're going to have to spend more time here in Philadelphia, because we now own a Medicaid insurance product with about 400,000 plus lives. It's being renamed now Jefferson Health Plans. So we'll have a lot to learn about, controlling.
Well, we would love to work with you, Mark.
So we'll do some business on the side here. What's next for you? I mean, that's not an insignificant leap to head out of Harvard and abandon all of that to take the plunge. And presumably this company, as it succeeds, will morph and go in directions that go beyond you. How do you see your career unfolding, and sort of what are the factors in your mind in terms of what you want to accomplish?
I think, to be totally honest, I wasn't necessarily looking for a new opportunity. 8 years into being on the faculty, that's when things start to get more comfortable, where you know what you're doing, where you've got a platform. And there are honestly a lot of things about academia that I miss a lot. Like I miss being, the objective source. And now I have a financial interest. And so when the CDC puts out new information, I'm not their go-to anymore. That being said, it was just so clear to me during the pandemic that we were not doing healthcare right. And it was always true, but I guess there's two approaches you can take to change. One is evolution and the other is revolution. And I had been raised within the conventional healthcare system and wanted to evolve it. And then the pandemic, there's rarely a poetic moment in life that's like a cinematic moment where you like radically change your life. I had one, which I don't think I've ever shared publicly, but Chelsea, Massachusetts is a part of the greater Boston area. It was, the hardest hit community during the pandemic. There was a woman who called me, when you're on OB call, you triage a lot. People call about whether they should come in. And it was a time where we had no capacity and you wanted to be very judicious about who you called in. And these were the early days of the pandemic where we were literally still like, have you been to China? And we got this slightly more evolved place where like, have you been to California or New York? But like we had a very crude understanding of risk and we had clinical criteria for when you were sick enough to come in. This woman called symptomatic and the only way you could be tested, by the way, was to come into the facility. And she didn't meet criteria. She wasn't sick enough to come in. And so I did what the triaging algorithm said, which was to tell her to self-isolate. And she couldn't because she lived in multi-generational housing and drove a bus. She had one of those essential jobs. And, I don't know what happened to her, but I'm like 99.9% sure she had COVID during that really tough early part of the pandemic. That happened. And so when, I talk to Kate Ryder every couple of years, who's the CEO of Maven Clinic. As a professor, you get to pontificate. But when she called looking for a chief medical officer, I wanted to be part of the revolution. And I don't know what's next, but I do think, what Maven Clinic is positioned to do, irrespective of what we do as a business, what we're positioned to do is push the whole industry to do better and be better by engaging a lot of the companies and sectors I mentioned in the social justice issues of our time, and honestly by injecting science into industry. I think digital health is in the prove it era. It has as much potential to impact people's well-being as drugs or devices. It doesn't go through FDA, and so it's not scrutinized. It's not given the same level of rigor, but it should. So that's what I'm up to in the next couple of years, is to raise the bar.
Sounds great. Let's open it up for a question or two from the audience. I think we may be running out of time. I think I messed up. I think I was supposed to stop earlier and ask you for your questions, but we'll tack on a little time.
Yeah, sure. Thank you so much. A couple of times.
Somebody give her a. Just because this is being streamed, so we want to make sure everybody hears it.
A couple of times in your talk, you used the word advocacy. You actually talked about powerful advocacy. And in my case, you're preaching to the choir. I teach health policy to midwives here at Jefferson. But I find engaging clinicians in advocacy challenging. So I wonder your view about the role of advocacy on the part of clinicians trying to make change, and how can we inspire people to be more politically involved?
That's a really great question, which I appreciate. I mean, I think that, part of what drew me to women's health is that it's like the last thing I thought I was going to do as a male in my mid-20s, to be honest. I did my OBGYN rotation first to get it over with. And I also found that it's really hard to care for people around their reproductive health needs without wearing social justice on your sleeves, or at least the people around me were, it's not that general surgeons don't care about social justice. It's just when you're operating the gallbladder, it's not the same thing. So I think that most people that go into the field are motivated by that. But I think that, I don't know, I think in some cases we don't always feel empowered to make a difference. I think bad systems beat good people. I also think that for a lot of forward deployed clinicians and particularly physicians, what we think of ourselves as leaders, but we don't always know the difference between leadership and allyship. What I mean by that is that what we really should be doing is, in our quest to make people safe, we sometimes treat their experience as a secondary luxury that you get to after you make them safe. Not midwives, but obstetricians do that. And what we should be doing is the opposite. What Bruce and all of these public advocates have taught me is that attending to people's lived experience is how you make them safe. And I think that's a concept that makes sense in normal life, but gets trained out of us, that we have to rediscover.
Great. One last question and we'll wrap up.
Thank you. It was very interesting. I mean, as a non-clinician researcher, what I was thinking about was when you talked about nutrition, for example, right? It's sort of on intersections of that with cultural and social backgrounds and so on. I wonder if the problem has to be formulated larger than a digital health nutritionist angle, because in many cultures, well before there was a computer or a cell phone, people told each other, even to this day, right? The mother or the mother-in-law or somebody else like that will tell you, you should eat this or not eat this or whatever, right? Or you should do it this way and not this way. And so how do you bring that back into the mix? And that also intersects with the trustworthy nature that you were mentioning about. So I wonder if you could comment on how all these things come together in some simultaneity of response, if you will.
That's such an awesome question. I mean, I think the existential challenge for our healthcare system is trustworthiness. And there's actually three ways that I think of operationalizing that, at Maven. One is, or in life, to be trustworthy, you have to be competent. It means you actually have to produce good and equitable outcomes. We're not doing that. Also, what's interesting is it's not sufficient. You also have to affirm people. And that means you have to have a level of cultural competency to do that. You have to understand that, a South Asian diet's not the same thing as, other diets. And with childbirth in particular, there's a lot of cultural, there's a need to one of the things that you can do digitally is you can match people to care on the basis of shared identity. And what we find by the data is that makes a really big difference. So you have to affirm people, and then you have to be reliable. We're so unreliable in healthcare. We're never there when we say we're always late. It's so hard to make an appointment in a timely way around a need. It's so hard that only 5% of people who are pregnant who have a mental health need get to see a mental health provider. Whereas over 30% of the people that we take care of say that we help them manage depression or anxiety, which is purely an access issue. And that's what happens when you're reliable and you show up when someone reaches out.
All right. I think we are time up. Sorry, you're gonna have to hold your question to the reception afterward. But the name.
Maven Clinic. I think it comes from Malcolm Gladwell's book, Tipping Point. I'm pretty sure. I've got to confirm that. But the Mavens are the people who lead the change.
All right. Well, thank you, Neel Shah. Thank you, President Tykocinski. Please join us for the reception afterward. And thank you for tuning in online.